So without much ado, we have our first speaker, Dr. Lawrence Fung. Dr. Fung is a professor of psychiatry, behavioral sciences at Stanford University, and he does many projects. So I'll let him introduce himself a little bit more, but I have a little blurb here that I'll read out. He directs the Stanford Neurodiversity Project and Neurodiversity Clinic, leads the Fung Lab. His work spans autism research, neuroimaging, and community-based interventions to support neurodiverse individuals. Trained at Cornell and George Washington University, he completed residency and fellowship at Stanford. Dr. Fung, please.
Thank you for the kind introduction, Dr. Richard Brown. And
speak a little louder.
Can you hear me back there?
Yes.
Okay, wonderful. So today I'll be talking about innovation through the neurodiversity lens. So some of you may be very familiar with the medical model, which is basically what doctors usually try to do is basically to figure out what's wrong and then you fix it. But autism is not about fixing. Autism is about understanding. So if we are thinking about fixing, that a lot of what autistic people are really good at doing will be taken away, which is not good. So basically, we are taking a more of a balanced approach using the neurodiversity paradigm. Neurodiversity is a concept that regards differences in brain function and behavior as part of normal variation of the human population. When we talk about neurodiversity or neurodiverse conditions, oftentimes we talk about autism. That's how the term neurodiversity started over 20 years ago. But in the last 10 years, really, it encompassed many other neurodiverse conditions listed here, like ADHD, dyslexia, motor disorders, even other neurogenetic conditions and neurologic conditions and psychiatric conditions. So for using the neurodiversity lens, we will be reframing autism. So sometimes in a medical model, when you see someone doing something over and over again, you call it perseveration. But afterwards, if you figure out that you have good results, then you have to change your tone and say, oops, it is actually persistence or perseverance. Autistic individuals tend to be drawn to details. They can see the big picture, but they have a tendency of like focusing on the details. So it really depends on what the person needs to do. If the task at hand is really about details, then you really have got the strengths of that person. So an autistic individual is very good in solving problems that require details. Usually, autistic individuals have fewer interests. When they are interested in something, they are just going to be diving in and trying to learn everything about the topic. So they become an expert on the topic. It may take a little longer for autistic individuals to understand other people's perspectives, but at the same time, they are very concrete and honest. Social interactions are different in autistic individuals. At the same time, they can be the most loyal friend you can ever have. So you see that there's one list of characteristics of autism that we have not changed, but it can be both strengths and challenges at the same time. What really matters is that if we are willing to make people in the environment to understand their strengths while also acknowledging that there are some challenges, then we are going to be more able to see their strengths. So in order to further operationalize these concepts, basically we need to build upon only saying it for a few, like just focus on the strengths. We need some more core philosophies that we know of that we have that we can build upon. So here are some of the very established fields that we basically put together, and collectively we have formulated the strength-based model of neurodiversity. So positive psychology is the first component of the strength-based model. Is really about understanding how to get a person to appreciate their own strengths, and they get fulfillment out of it, and also have a developmental perspective in mind. So have a growth mindset, in other words. Positive psychiatry, in contrast to traditional psychiatry, is basically an approach to think about in situations that the individuals are not in crisis. Like in traditional psychiatry, people definitely need medications and short-term psychotherapy in order to get out from depression or even suicidal behaviors, etc. But when they're well, there's no point of keep asking them about their depression. It's actually better off to help them to think about how to develop themselves. And then that approach is going to get them to stay healthy, and they are not going to be drawn back to the depression or anxiety that they are struggling with. And then Garner's theory of multiple intelligence is basically a more broad approach of thinking about intelligence. So a lot of the time, when you think about intelligence, you think about IQ. But IQ test only tells you about three things. It's only verbal ability, logical ability, and visual spatial ability. It doesn't tell us about anything else. What about others, like musical ability, athletic ability, intrapersonal, interpersonal ability? All of those are actually not captured. So basically, Garner's theory of multiple intelligence is allowing us to capture all the other intelligences so that we will appreciate the other kinds of abilities that's beyond what IQ tests can tell us about. And then the last component is Chickering's 7 vectors of development. It's basically the 7 developmental tasks that all young adults and adolescents have to achieve in order to become a full adult. And basically, it tells us that the developmental approach is what we want to use in order to meet those developmental milestones. So when we are thinking about the strength-based model of neurodiversity, we also emphasize that the neurodiverse conditions are conditions rather than disorder, and acknowledge challenges instead of deficits. And the reason for that is exactly in the last slide. If we are calling autism disorder and calling everything that's on the right side deficits, you're going to be stuck here forever. You're not going to be able to see the other side, the strengths of autistic individuals. And that's why we need to pivot and really use the terminologies that can allow us to see both sides, knowing what the strengths are and maximizing the opportunity for growth, while acknowledging that there are some tendencies that may surface as challenges. And lastly, we want to apply the entire approach across the spectrum, the entire spectrum of neurodiverse conditions. So people on the autism spectrum can be speaking, and there are also those that are like Siri that are non-speaking. And the entire approach here is applicable to everyone on the autism spectrum. So this is basically a contrast between traditional psychiatry and positive psychiatry. And basically what I was telling you is traditional psychiatry is focusing on what's wrong and you really fix problems, but positive psychiatry is really about protective factors, neuroplasticity, and this can increase well-being and growth through psychoeducational intervention. And this really makes it a preventative approach. So if you apply the strength-based model in neurodiverse individuals, you would raise their awareness of personal abilities, that if you increase their trust in about their personal strengths, and also help them learn to engage in meaningful relationships and increase their self-satisfaction through success. And this way, you will move them away from the negativity, such as anxiety, depression, and executive dysfunction. On one hand, we use a very person-centered approach, focusing on the neurodivergent person. On the other hand, we are using an ecosystem-driven model. Everyone has family, friends, and neurodivergent people oftentimes have mentors and therapists as well. In the education setting, there are teachers, coaches, classmates, roommates that can make the immediate environment more neurodiversity friendly. And the larger environment can also make the educational setting more neurodiversity friendly by changing the culture. And similarly, in the employment setting, the people closest to neurodivergent people, such as the supervisors, job coaches, and colleagues, can make the workplace more neurodiversity friendly. And the executives, the work community, can also make the company culture to be more neurodiversity friendly. And lastly, in the healthcare setting, the therapists and the doctors can make the clinical setting more neurodiversity friendly. And in the larger setting, in the hospitals, even in the insurance companies and professional organizations, they can also contribute to using a strength-based approach so that they can make the culture of the clinical assessment and treatment to be more neurodiversity friendly. So basically, this diagram gives us a rubric on how we are going to be focusing on different stakeholder groups in order to help them change the environment. So basically, our solution is not to fix anyone on the autism spectrum because it is not the right approach. Basically, what we try to do is to help people that are around neurodivergent people to help them change their environment so that they can make it more neurodiversity friendly. So over the last 8 years, we have many projects. So initially, we have a special interest group for neurodiversity, and we have, in the last 8 years, initiated 3 initiatives: the Neurodiversity Clinical Initiative, Neurodiversity Education Initiative, and Neurodiversity Employment Initiative. And basically, I'll tell you a little bit about our newest work on neurodiversity in culturally equitable intervention project. And until 2 days ago, we are still officially Stanford Neurodiversity Project. 2 days ago, we got approval by our School of Medicine to call or designate our group as a center. So now our group is Stanford Center for Neurodiversity and Human Potential. So this is basically telling us about the endorsement from the School of Medicine and our department on how important this approach is. And in terms of the NICE project, NICE intervention project, the first thing that we are trying to do is to really define what neurodiversity-informed care really means. That's a kind of a lingo that some people use, that they say they are doing work in a neurodiversity affirmative way, but there is no definition. There are a few papers here and there that are trying to describe it, but it's not really empirically obtained. There's no consensus. So basically, over a year ago, we did a study after having a group of stakeholders, including parents and autistic individuals and healthcare providers and mental health providers. And collectively, we created a survey. And the survey was sent out to actually about 12,000 people. We eventually got about 300 people actually finished the survey. And one of the questions is about the principles behind neurodiversity-informed care. And after the community consensus with over 300 people, we also sent out the survey to the experts who are department chairs in psychiatry or division chiefs in psychiatry or psychology, and also like master clinicians and researchers. And basically, what we have found is that you see the orange bars are the community stakeholders' responses, and the blue is the experts' consensus, experts' responses. And for the large part, there is basically very little discrepancy. The experts and the community actually agree with each other on what are the main principles. So the words on here in this graph is very small. And basically, in order to really get us to really understand what it is, what are the core principles, it is actually boiled down to an acronym, RESPECT. So this RESPECT acronym tells us what are the agreed upon principles that of neurodiversity-informed care. So R stands for real-life experiences valued alongside clinical expertise. E stands for embrace the strengths and challenges of neurodivergent conditions. S stands for systems adapted to reduce barriers that neurodivergent people face. And then P stands for partnership with medicine, not exclusion from it. And then E stands for environment flexible and responsive to individual needs. And C stands for comprehensive health focus, physical and mental for quality of life. And last but not least, T stands for trust and respect at the heart of every decision. So basically, with this list of principles, we now have a consensus from the community and the experts. And now we can actually develop something that will be consistent with the principles that we agree on. So in the last 7 months, our group also worked with the community stakeholders to co-develop a set of interventions. And basically, it is a curriculum that's targeting primary care providers and mental health providers to make the clinical environment more neurodiversity friendly. And these are the titles of the 10 modules that we have. So the first 3 modules are kind of basic information about what's neurodiversity and what is neurodiversity-informed culturally equitable approach. And then we try to explain what are the myths and misconceptions about neurodiversity and get people to understand what is really the truth. And also, we developed something that we call neurodivergent person snapshot, and we explained in one of the modules. And this is basically an attempt for us to get the neurodivergent people to tell the providers about what they need, what their preferences are, what their interests may be, and what are their strengths, together with other relatively sensitive information that they would like the provider to know ahead of time. And a lot of the time, like really to get the clinical environment more neurodiversity friendly, it is actually not that hard. And but people just don't do it because they don't know how to do it ahead of time. So if we are able to provide the information, like have the neurodivergent patient fill out the information ahead of time, and then the doctor knows that, for example, if someone is sensitive to light, like fluorescent light, then they may decide that they would just use another room that has natural light. So things that are actually doable. And so that's one of the interventions that we described. And then the other 7 modules are basically vignettes in different settings that are very common that we see in patients that have to go to the clinic. And basically we have 2 contrasting examples for each vignette. One is about, like, if you don't use the NICE approach, what is the outcome? And then the other is, if you use the NICE approach, what is the outcome? And clearly, using the NICE approach will give you good outcome. And if you don't use the NICE approach, you're not going to get an optimal outcome. So basically, right now, we have completed the development of these 10 modules. They are actually about like 10 to 15 minute long videos, and there are quizzes that can be helpful for the learners to consolidate their learning. And basically, we are starting our feasibility study. So I don't know if this works, but this is the trailer. Oh, and I think it doesn't work. Anyways, so if you go to our website, if you Google this, neurodiversity informed, culturally equitable, NICE, or scan the QR code, then you'll be able to get to our webpage. And then there's a trailer that's basically the one that I show you is on our website. So basically, what we are trying to do is to find providers that are willing to be working with us on testing this set of curriculum. And then we would like them to also have their patients involved in this study. And then we'll be able to see the effectiveness and feasibility of delivering this NICE curriculum, as well as the use of the NPS. So with this, I'd like to thank you for your attention, and I'll be happy to answer any questions you have.
Dr. Fung, first of all, thank you for the presentation. I really enjoyed that. I keep on thinking as you're talking about this, kind of like the basic respect, the basic kind of growth mindset that I think that anybody would want you to have, not just neurodiverse individuals. Like, you know, my children, whether they're neurotypical or not, I want them to have a growth mindset, and I need to, as a parent, have that growth mindset. But internally is kind of an internal dialogue that determines how I interact with these people. Do you deal at all with that internal dialogue, kind of the basis thoughts that help me either as a parent or as a therapist or as a teacher to be able to, interact with autistic individuals in a way that dignifies them? You go to that core. How far down do you go in your work?
So basically, the reason why we form focus groups that include like parents, autistic individuals, and mental health providers, primary care providers, is that we need them to tell us about all those deep thoughts that they have. So the first approach, the first step of our design thinking approach is to exactly do that. We need to know deep down inside what is really the barrier, what are the pains and gains, so to speak. And by understanding that, we know what is actually going to be most helpful in order to develop something that can actually change people's practice behavior.
And in terms of kind of the reverse almost, now that you have, we've listened to autistic individuals, we've assessed where they're at, how they want to be treated, then going reverse to how do we then change ourselves to that? Do you go through any practices that are kind of the reverse, going down the other end of that tunnel?
That's why the providers are also in the room.
Yeah, okay.
So all the stakeholders are in the room.
Nice, thank you.
I have a couple questions. The first one was about you said that you sent out 12,000 surveys,
Yeah.
and only 300 were returned. Who did you send, who got the surveys?
Yeah, they are basically in our network. The Stanford Neurodiversity Project basically have about like 12,000 followers.
And only 300, was there any incentive?
We don't have any incentive. We don't give out any honorarium.
No, I'm trying to, a lot.
Starbucks gift.
I talk to a lot of parents that want to participate. It seems crazy. I know I've talked to parents who are like, I want to be involved in research, and whatever I can do, and then only 300 people respond. It surprises me. I wonder what we could do to improve that.
So one thing that there is also a lot of details about who's actually completed the form, and it's very interesting that 80% are women, and also more than 50%, about 60% of the respondents. 300 is not a small number either. 60% have masters and above degrees.
Okay.
It's very unusual. So the people that are that want to actually contribute tend to be more educated.
And the other question I had about the NICE training model, as an autistic kid, I was not able to explain to my provider what I felt there was, and part of it, you said, is that having the autistic individuals ask for what they need. How do we deal with that when a lot of them don't have language yet for what we need?
That's a very good question. So actually, our group has some students that develop something that we call it NICE cards. So basically, there are a lot of questions, like 40, 50 different kinds of questions. Basically, trying to is like a card game, playing with them, talking about things that they like to talk about, and trying to really help them open up. And sometimes maybe they don't have some people may say they don't have the words, maybe some will be able to describe things in a different way, but a lot of the time it's really about engagement. When they are not feeling comfortable with the provider, then they are not going to be as effective in the conversation. So basically, we try to help with that.
Thank you very much.